with the aim to promote self-management of type 1 diabetes. We can start now.
Role of the Pediatric Diabetes Specialist Nurse in delivering education, and the aim is always to promote self-management of diabetes. Education underpins every aspect of being a Pediatric Diabetes Specialist Nurse. Our role is to empower our young people and families to have the knowledge and skills to be able to self-manage their diabetes, make them the expert in their own diabetes. When I see that sentence, diabetes is the leading cause of, it often ends in a negative sentence, such as diabetes is a leading cause of complications, for example. What I want to say is that diabetes is the leading cause of courage, understanding, maturity, grit and guts. This is what I see in the young people that I look after and support. Diabetes isn't easy, it is relentless, and it has no end. Every young person's journey is unique to them. We support young people from birth to 19 years, all at different stages, all on their own journeys. Embedded within this, we have a transition service aged from 16 years up to 19, where we work with our adult colleagues to support our young people transitioning into the adult clinics. There is no cure. I always apologise to our young people and families, especially at diagnosis, that we can't take this away from them. We can't stop it. But what we can do is help them to learn how to manage their diabetes and continue to reach their full potential and aspirations. As I said, there is no cure, but what is helping not just to improve our outcomes for young people, but also their quality of life, and also to try and ease the relentless 24/7 burden of living with diabetes, is technology. But technology is only as good as the user that uses it. If you don't know how to use the technology or know how to get the best out of it, then it can become unsafe. I am the Pediatric Diabetes Specialist Nurse. My role is crucial in providing good patient care and promoting self-care management. But I am part of a much bigger multidisciplinary team. We have a consultant and doctor with appropriate training in pediatric diabetes. We have pediatric dietitians with specialism in diabetes and also a pediatric psychologist. Our team has healthcare assistants and administration staff to support our service, but also we work collaboratively with internal providers such as the acute children's ward and external providers such as educational environments, schools, colleges, the local authority, mental health providers, extended family members. Basically, wherever that young person goes, we're there to make sure that they have the correct support and skills, or their carers do, so they can continue alongside their peers and enjoy their life. We have a holistic approach. Often, as a diabetes specialist nurse, we can be wearing many hats at the same time. We are seen as the clinical expert in diabetes. We assess, plan and implement care. We're sharing our expert knowledge, not just with young people, but with other professionals. We also run independent pediatric nurse clinics. We are autonomous workers. We're problem solvers. We also signpost all our families to other agencies for support. We promote a solution-focused approach, looking at goal setting, working with our young people to get the best out of their diabetes. We are not dietitians, but nutrition, especially the carb counting aspect, is one of the cornerstones of diabetes care. We as the nurses also support our families and schools with the skills to be able to manage their diabetes safely. We offer emotional support, low intensity initially. We are the key nurses from the outset. We become involved with the young person and families, not just with their diabetes. We know if there's chaos going on for that young person or within the family home or school, and this will be impacting on their ability to prioritize and have the motivation to safely manage the diabetes. We are seen as the gatekeeper for our families to reach out to. We build up a trusting relationship and often can be the one to notice and start a conversation if the young person or family is seen not to be coping. We also link in with our external mental health providers. Partnership working is essential. We also recognise the importance of safeguarding our young people from harm, early intervention or escalation to the local authority for child protection involvement if needed. We assess and provide reports to support our concerns and work alongside the local safeguarding teams to ensure positive outcomes for the young person. We are a coach, teacher, motivator. Every contact education is discussed. The whys, the whats, and what's needed to happen, problem solving along with the young person to promote them to learn these essential skills. We have also more recently become tech experts, technology experts. This is advancing all the time. Young people are very confident in using technology today, Xboxes, PlayStation, computers, etc. But education and support is still needed, not just for the young person, but for the parents and teachers who need to support or supervise the diabetes routine and the technologies that's involved in this. This often can appear to increase the burden of managing and supporting somebody with diabetes and also increase their anxieties. Being part of the multidisciplinary team is to deliver consistent, high-quality care to children and young people with type 1 diabetes. Evidence-based practice underpins all of our practices, and I've listed here some of the guidance and policies that we follow, and I'm sure you will have your own set of guidance as well. We access national guidance to support our young people being able to access technology. Also to ensure we follow an accredited patient education program about using technology such as insulin pumps, pods, continuous glucose monitoring or flash monitoring. As discussed before, using a device needs to be safe, but also that the young person gets the best out of that device. Our education program includes many topics, and I've listed on the slide here the majority of topics that we cover. It's not just about what we teach though, but it's about how we deliver it. Education needs to be tailored towards the individual needs of the young person and family. It needs to be age appropriate. What we tell our younger children is so different in our approach of how we educate our older children. Understand the need to tailor the education that you are delivering towards the young person and family. Understand their individual learning styles, evaluate their learning, and be able to adapt our approaches as needed. There needs to be an assessment of learning needs. Is there any special education needs that we need to be aware of? Is there any autistic tendency, whether the young person or family members? What are their literacy and numeracy skills like? The emotional impact, especially at diagnosis, can cause anxiety and impact on their learning. Also, psychosocial aspects such as their social background, their own culture and their life goals all need to be considered when delivering education. Many families describe it as being like a jigsaw. When they first start on the diagnosis and their journey of learning, it's as if all the pieces of the jigsaw are scattered everywhere. But we help and support and guide our young people and families to be able to start to put the pieces of the jigsaw together so they get these essential skills. No matter what the education program delivered, whether it's diagnosis or starting on different new technologies, families and young people always express that overwhelming feeling, that starting again syndrome, needing to rebuild on their knowledge and skills all over again. Education starts at diagnosis and continues throughout. Every contact counts. In addition, as access to technology grows, there is a need for services to ensure they deliver a robust continuing program of education, allowing young people to understand and manage their diabetes effectively. As we say, every contact counts, from diagnosis in the clinical environment, telephone, home visits, school visits. We offer peer group education sessions. In their annual review clinics, we also start reviewing their understanding of diabetes, and the same can be said on technology. It's not just delivering education at the beginning, but it's an ongoing learning. The immense impact on all aspects of the child's life cannot be underestimated, though. Type 1 diabetes is lifelong, but it is also life-threatening if not managed appropriately. As each family's needs will vary, so does the amount of support and education required. It is important to recognize possible barriers that can make accessing or being competent in using technology. So if we look at the impact of diagnosis and the emotional impact, that shock, that anger, acceptance, being overwhelmed, it's similar to somebody that's going through the grief process. And we're coming along now to say, right, we need to learn that we'll have poor retention of information at this time, and we need to respect that and work with them at their own pace. Ongoing barriers could be the burnout, the mental health exhaustion of living with diabetes. It's relentless. Young people want independence, but there's a fine line between them being able to be independent and where we need our families or teachers or other support relationships to be able to continue and support that young person when needed. Adolescence, that age group, also brings along risky behaviours. Some families have limited access to technology or even have anxiety at the thought of using technology. There are social demands in that young person's life and also within the family dynamics. They have different priorities, what our priorities may be. They have concordance and compliance with intense management regimes, the peer pressure, the stigma, and also body image, especially if wearing devices and sensors. External barriers could be within our own workforce. To be able to deliver this education, we want to make sure we've got the right skill mix within our teams with the expert knowledge and skills to provide this. As talked about already, it's understanding if there's any learning barriers, special education needs, autistic tendencies. Is there any safeguarding currently going on within that young person's life? And also the eating disorders. We need to work with our children and young people to help them reach their goals, become confident and competent in self-management. The language we use does matter. Communicating the same correct messages is a must. Avoiding mixed messages. along with adhering to the same guidance and policies. Children and young people and their families do actually talk with other families. They source information from platforms such as social media. They know themselves what is available, often before we do. They are defined as the expert patient. We need to be mindful and reduce the risk of health inequalities. This can lead to lower uptake of accessing technology for some young people. Services need to have a transparent approach and work with the commissioning groups and providers and healthcare professionals to reduce the risk of these health inequalities. Education programs can differ from diagnosis onwards. However, the basic knowledge, that core knowledge, remains the same. And on this slide, I've just demonstrated a general curriculum that we deliver to all our patients at diagnosis. It is a continuous though, throughout every contact, along with passing the knowledge and skills on to that young person themselves as they grow and seek independence to manage their own diabetes. We share local and national resources in the UK to support our young people, and I'm sure within your own area, your own country, you will also have your own resources. These resources can be used whether a diagnosis, ongoing to deliver that education, or starting to use technology. DAP aims to deliver the full primary diagnosis curriculum via a structured education program. It combines visual, auditory, kinesthetic, and emotional learning approaches to embed this knowledge. DigiBeat is seen as a digital diabetes passport. It holds all the essential information that young person needs. It's at their fingertips all the time. The young person often forgets their essential kit bags, their finger pricking devices, their technology, but they never forget their mobile phone. So this allows them to have good communication and news from the clinic and keeps open good communication channels. SEREN is also an accredited structured education program, and it has different programs, for example, from diagnosis, moving from a primary to secondary education, transitioning from children to adulthood, technology, and these only name a few. They have several education programs that we can access to use alongside of our young people. When we talk about technology, we don't just mean insulin pumps or continuous glucose monitoring or Libra flash systems, but this now involves bolus calculator apps and smart apps, also smart pens which track the insulin delivery. Each device also comes with a platform that links the young person to the clinic virtually, looking at downloads together, interpreting the data together. Data can often be seen overwhelming. It is about learning what is useful, not just for the healthcare professional, but for that young person and family. The type of data we look for is the time and range, the goal setting. Do we need to adjust the young person's doses of insulin, whether it's the basal insulin or the bolus insulin? We're looking at problem solving. Is the young person bolusing? Are they including the carb count as well as the blood sugar? Are they actually delivering the insulin at the right time? Or are they missing doses of insulin during the day? The journey to start and explore technology has to begin with the young person. They need to want it. We talk expectations with our young people and families when they approach us about looking at different technologies. We signpost them to research what we have available for them. We link them in with the expert in the technology, the company representatives. We ask them to access online learning resources, but we also ask them to seek peer support. The best people to give an honest answer about different devices that can support diabetes management is from the people that are actually using these devices. Some young people, they may need a trial of a device before we go ahead, and this is because they might just have a bit of anxiety. How does it feel to be connected to a device? So often a trial can hopefully help them overcome this anxiety. But we also need to talk through the expectations with what we want the young person to engage in to ensure they get the best out of the technology, outlining goals from the beginning, not just to be seen as a contract, but a conversation that can be revisited. It includes dietetic support, ensuring that we've got good carb counting skills to support bolusing, to be able to use these features to use extended boluses for different types of food groups. Psychology input's essential. Is there fear of hypos? Is there a fear of injections and needles? We need to engage in education programs, not just initially, but they have to agree to continue to engage in any education programs provided. And even before they go live on a device, we want our young people to download to the Link platform to ensure we can have virtual clinic and successful reviews to be able to help and support them with their diabetes. There is a need to talk with our young people and families about possible problems prior to the start. We need to be open and honest. The conversation is part of this expectation discussion. The aim that the young person uses the tech effectively to manage their diabetes and use the tech, such as continuous glucose monitoring or flash, to have a positive effect and not just to be seen as a punishment. We need to be working together for better outcomes. We use many different resources, the resources that are often provided by the tech companies themselves, along with using our local representatives to support with technology start and education. When a young person comes along and shows interest in wanting to start on technology, we signpost them to access the academies. We ask them to go on the learning zones and use the online resources. When they start to go on that device from the outset, with the support from the healthcare professional and the local representative, is for them to set up that device, start the button pressing, start to work through and navigate through the menus and the different features, beginning to understand what that pump can do and develop problem-solving skills from the outset. We together work through and complete an education program checklist to ensure all education has been delivered and understood through evaluation of learning. And I've got an example. I know it's very small, but it's a basic example of a typical checklist that we use. For young people continuing to use technology, we want to make sure that they're using all the features correctly. They're achieving the good glycemic control in time and range. We want to know that they're using their problem-solving skills, especially around hypoglycemia, hyperglycemia, sick days, that they're using the alert and the trend arrows on their devices to try and prevent these lows and highs occurring. We understand where to start with setting alerts and linking in with goal setting, what is appropriate for the young person, but also we want to make sure they set the alerts and alarms appropriately. We want to avoid burnout. Using trend arrows and insulin adjustment tools can help to make sure that they're getting the best out of their boluses to have effective blood sugar control at all time, aiming for a more higher percentage of time in range. Again, on the slide, I've just got an example of an education checklist that we do in all annual reviews. making sure that a young person still understands how to use their device safely, but also still has the confidence and competence to continue and use it. But in a positive way, it can help identify if there's any gaps in knowledge. If we do notice any gaps in knowledge, then it gives us the opportunity to provide that information for that young person, to give them the opportunity to re-engage. By using accredited guidance, it ensures a structured programme is delivered from the outset. And I've given two examples here of guidance that we use. The Association of Children's Diabetes Clinicians for Libre Flash Glucose, but also for the Dexcom Continuous Glucose Monitoring System. These platforms give clear steps and aims for our families to work through, ensuring successful and effective use of technology and be able to support the diabetes management in the long term. We know no matter how good you are at managing your diabetes effectively, hypos will still happen, and you can be left scratching your head as to say why, often then saying, what did I get wrong? Which is often nothing. It is what it's like living with diabetes. No 2 days are ever the same. What we want our young people is to recognize if their blood sugar is too high or too low. Use the technology to help reduce the risk or prevent a high or a low, and also to safely treat their blood sugar. As part of the education program, we include why highs and lows may occur, how to reduce the risks, and also the signs and symptoms. Technology is benefiting our young people living with the burden of type 1 diabetes, but it is only technology, and sometimes you can get technical faults or even user faults. It's essential that our young people know when they may still need to finger prick, but also the importance of why they still need to carry their finger prick along with all their other emergency kit for their management of diabetes. We want our young people to use the trending arrows and alerts as learned in the education programs provided. Use the dose adjustment tools also provided to reduce the risk of hypos or hypers. Treat hypos correctly, avoid unnecessary treatment or over-treatment, similarly for hyperglycemia. Use the data that these devices give you to learn your own trends, especially post-meal time boluses or for activity, looking for trends and patterns and reviewing the insulin requirements. And we again use approved, accredited policies and pathways, so the same messages are always given to our young people. You will have your own clinical guidance on the management of hypos and hypers, but in the UK, we use the national guidance as the Association of Diabetic Clinical Guidance. This is to ensure that these correct messages are given, but also to use the resources identified in this slide that we allow our families to access. The aim is very much similar to what I was discussing previously, using the trend arrows, preventing high blood sugars to drift, problem-solving solutions, especially for our young people on pumps and pods. We want to prevent diabetic ketoacidosis, especially if they're on the insulin pump or pod. We want them to manage their sick day rules correctly, react sooner to be able to prevent the short and long-term complications of living with diabetes. I just want to say thank you very much for listening to my presentation, and if you have any questions, please feel free to email me and I will provide my email address so you can do this. Thank you very much.
Very much, Alison. Thank you very much indeed for your excellent presentation. And I think we will send you a lot of questions to be answered as soon as you can. Thank you very much indeed. Now, we move on to our next speaker,